Well, we're here with Dr. Bill Weeks and Dr. John Ventura. I'm Dr. David Peyton, chiropractor from South Africa. Dr. Weeks, thank you so much for joining us.
It's my pleasure to be here. Thanks for having me.
Great. Would you give us a little update and background about yourself and your journey?
Sure. I am a psychiatrist by training, originally clinically. I grew up in Oklahoma, went to med school in Texas, and then came up to Dartmouth, where I've been for about 30 years now. Having done my residency in psychiatry, I also focused on addiction psychiatry. And then after that, pursued an MBA at Columbia and a PhD in health economics in Europe. And mostly what I've been doing for the past 25 years or so has been what we call health services research, where we look at how people use the healthcare system and how to make that use more value laden, in that outcomes are better and costs go down. So it's kind of the triple aim that we've been pursuing here, with better quality care, better patient satisfaction, and lower care costs, to try to kind of use that to drive the research agenda that we've been pursuing.
As I understand, you're at the Dartmouth Institute at present. What is your current role? What are you specifically doing right now? What's on the cards for you in 2018?
So I'm a professor there and a senior researcher. What I'm doing right now, I'm doing a variety of things. I've been looking at chiropractic care and how chiropractic care might be useful in particularly the Medicare population, and what the upsides and the downsides of chiropractic care use are there. I've been looking at end of life care costs and variation in that cost. I'm really excited about this new work I'm doing, where I'm trying. We found a decrease in end of life care costs since about 2009. It's really driven the overall Medicare cost mitigation. So Medicare cost curves were going up, and then they flattened around 2009, 2010. But that was really driven by about 54% of that was driven by changes in end-of-life care costs that plummeted. And so the question is, why did that happen? And we have several speculative ideas, one of which is the financial crisis of 2008 was well timed to cause that. Also, there's been a real change in the makeup of the physician workforce. The palliative care physicians are more prominent now. It might be more kind of acceptable for people to have more conservative care at the end of life. And it may be just actually the Affordable Care Act might have caused people kind of to direct their physicians to direct efforts more toward newly insured and less toward people at the end of life. So we're working on trying to figure out that right now. And then I just look at variation in healthcare services utilization and try to think about how we can learn from that variation, because the beautiful thing about variation is you can see that some people are doing it here and some people are doing it here, and there may be reasons for that, but how can we learn from that variation to kind of achieve more value? And finally, I'm working with this organization, a very large international insurer called Bupa, which is all over the world. They may be in, I think they're in Africa as well. And we're working on them as Dartmouth is their academic partner to help them achieve their mission of improving lives, having healthier and happier lives for their clients. So we're doing stuff like that.
Bill, can I ask you to expound a little bit on one point you raised? I know spine is just replete with wide variation in care. And one of the challenges there is then bringing that information to the clinicians and getting shifting in behavior. And have you addressed that aspect of it, or are you, with your work and research, what are the strategies that can be employed to try to get behavioral change among clinicians when you see areas of wide variation?
Yeah, so the first thing you start with is just showing the variation. And that sometimes has an effect and sometimes doesn't. And I'll give you just an example. About 15 years ago, we were asked to go to Casper, Wyoming, because there was a guy there who was working in a neurosurgical group who was embarrassed because Casper, Wyoming, in the Dartmouth Atlas, had repeatedly for the past 10 years been the highest user of spine surgery in the US, right? And so he brought us there. And he said, "Can you guys consult and show us?" And we looked and we said, "Well, just tell us about your environment." And in Casper, Wyoming, which at the time I think had a population of like 60,000 people, there were 4 MRI scanners, 4 competing neurosurgical groups, and he made the point that if you tripped on the sidewalk before you actually hit the pavement, you could be in an MRI scanner where they're going to find something wrong, right? They're going to invariably find something wrong. And so, of course, surgery. So part of it has to do with supply. So that's the easy thing, is showing it and then kind of saying, well, yeah, you have way too much supply. The harder part is managing that supply and changing behaviors, as you're pointing out. And that is, I think, a real challenge, because frankly, what you need to do, and we've done a little bit of it here at Dartmouth, is you need to restructure the workforce so that you have fewer of the specialty physicians doing that. So, and that the people who get to them have been adequately screened, including having shared decision-making being part of that screening process, to make sure that they get the health care that they want and need, and nothing more and nothing less. And that's our kind of mantra at Dartmouth. So you have to restructure the physician workforce. And then I think part of that, though, is figuring out what is the proper workflow to make sure that patients get that care that they need and they want, but in a way that is also good for them and maximizes healthcare value. And there, I think we're talking about interventions early on. If we're talking about spine pain, which, as you know, is a massive problem worldwide, and in the US it accounts for a huge amount of costs and huge amount of disability, the idea is kind of early intervention with conservative care practices seems to be more effective at getting people back into the workforce, not on the disability rolls, back into the workforce, and avoiding, unless it's absolutely necessary, surgery. Because surgery is exceedingly expensive and has its own series of complications, including later resurgeries and disability and things like that. So that's kind of the idea. And I think some of the things I haven't personally been involved in as much, but have read about and understand, is placement of non-physician providers like chiropractors or physical therapists. And my favorite thing, and I think it sometimes upsets chiropractors and physical therapists when I say it, but one of my favorite things about them is not only that what they do is really helpful, but they cannot prescribe medicine. They cannot prescribe opiates, and they cannot prescribe benzodiazepines, both of which, me as an addiction psychiatrist who treats people with heroin addiction, about 70% of whom of my patients started out with legitimate prescription medications because they had an injury, and they move on and they get addicted, and then off we go to the races. And 10 years later, they're still on meds for that kind of thing. So we treat, to avoid all that kind of stuff, you get people who can't prescribe that, who provide conservative care that works. It is really effective about 90% of the time. Most spine pain is self-limited, and for the 10% that's not, then you use a specialist. You're using the care appropriately. You're not wasteful in that. You're getting people back to work, and you're avoiding both the longer-term complications and this the horrors of addiction, which are not a good thing for patients to have, or for society.
Yeah, Dr. Weeks, you published what was it, an editorial, or you published some years back a personal anecdote that was a big shift for you. It created a big shift for you towards the necessity of conservative management and the avoidance of opiates. It was related to your sister. Would you be willing to give a sort of a flyover of what that was and how that has influenced your thinking on these matters?
Yeah, absolutely. So my sister is a kind of a classic example. She was doing well, we were raised pretty good, and I think in the Midwest, and she was doing well. She was a lawyer working for the state of Oklahoma, advocating for child protection, and she was doing really well. And she had horses. She loved horses. She was thrown from a horse, hurt her back, was put on opiates over a period of 15 years, was on incredible amounts of opiates of a variety of types, as well as benzodiazepines. She started drinking a lot, and she ended up, this person who had been, she ended up from being a successful, productive lawyer who's contributing to society and kind of making society better by watching out for children, to someone who was, on Medicaid, on Social Security disability, fully disabled, on a slew of medications. They kept her fairly confused all day long. And eventually, when her physician, who had been prescribing her medications for 16 years, quit, she couldn't find a replacement doctor. She ended up going to the emergency room, ended up in jail, and died in jail at 49 years old, which is a really sad end for someone who had a lot of potential to help society and became kind of a, more of a burden on society in a way. So that in combination, I mean, I can do, I'm an addiction psychiatrist. I had just been doing research for quite some time. And so that, in as well as just watching these, the death toll rise from opiates, made me think that this would be something I could be useful in doing. And I think even as an economist, it's kind of attractive to me, because you really are taking people in the treatment I do who get on the opiates. When you treat them with the medication-assisted therapy, they call it, things like Suboxone, or naltrexone, you actually are changing them from contributors to a black market economy, where a number of them have legal problems, or they're selling stuff or stealing stuff to get this these illegal drugs into a market where they're productive members of society who are tax paying and taking care of their kids and not as much of a social burden. So I think it's a good thing from an economic, and they're just much happier. When it's the most rewarding thing I've ever done in psychiatry, because they come in and they're train wrecks. Their lives are just a disaster. And in a month or so, they're back on track. And in a couple months, they got jobs and they're working and they're with their kids and things like that. So it's quite rewarding work.
Oh, phenomenal! As a 30-year practitioner, initially I thought chiropractors should try to move towards getting limited prescription licenses, but I've come away from that. I flipped completely with that, and I see the distinct advantage of just what you mentioned, is that using frontline practitioners in spine care like chiropractors and physical therapists who practice in a very patient-centered, evidence-based model and cannot prescribe is such a distinct advantage.
It's an advantage because there's not that discussion.
No.
And it doesn't even, then it doesn't become around meds, it becomes around my back. How do I get my back instead of the meds? I think one really revealing study for me, and unfortunately, I just can't remember the author of it, but there's a really well-designed study. There were 90 people in 3 different arms. One arm got medication management. One got, I think, just some exercise videos, and another one got chiropractors and physical therapists. And they all did about the same. I think actually the medication management did a little worse from a pain perspective, right? But they all did about the same, and certainly no worse. But then you look, there was a hidden table. So not in the actual paper, but as a supplement, there was a table that articulated what the side effects were, what the adverse events were in each of these groups, right? And in the chiropractor and the exercise groups, some of the side effects were kind of pain, right? So if you have pain and you're working on something that hurts, it's going to be a little painful. So they'd have pain. I mean, that's kind of to be expected, but they had to write it down because it was a study, so that was an adverse event. And that happened, that was a quarter of the time or something like that. When you looked at the medication management group, and you could figure out that I think 90% of them were on benzos or opiates or a combination of the two. And you look at they didn't have pain. That wasn't their big thing. It wasn't kind of ongoing pain, even though, mind you, at 12 weeks, the pain scores had gotten equally better and all. So the adverse event wasn't one of pain. It was one of grogginess, confusion, inability to sleep, constipation, all the stuff that are associated with these drugs, right? That make people not be able to work. So it was a really revealing thing to me to say exactly that these are kind of, not only are they, they're not just not good, they're bad for people. They really they foster a dependence in a variety of ways, not only on the medication, but on just not getting better and then having a whole different slew of unrelated symptoms to their original one. So I think that is a distinct, I'm glad to hear that you say that that's a distinct advantage, because I absolutely think it is. And I think if you go the other way and you pursue meds, it's going to be the same thing, because they're all going to, patients will ask for meds. They do. We know they ask for meds. We know from the Gallup poll that a lot of them are interested in not pursuing medications, but a number of them will ask for meds. And if it's not an option, it's just not discussed, and there you have it.
Yeah.
You know, one of the interesting things in South Africa, from a chiropractor's point of view, is that, and physiotherapists, we cannot even refer for an MRI, which is in itself useful as well.
Yes.
It creates the same kind of conservative emphasis where you're not going to be inclined to capitulate to the pressing of a patient. Oh, I need an MRI. You know, I've got back pain.
Right.
You just can't do it as quickly and easily.
Yeah.
So
you're going to be very selective of who
you're going to be
needs
selective, and in that way it's helpful. Whereas I understand you can refer for MRIs here as chiropractors in the States.
Yeah.
So you should take a leaf out of South Africa's book.
Well, the challenge about MRIs, and this is work done with Brian's group, is that, you know, the way the radiologists do it, I think in part because of legal issues, you know, legal concerns, malpractice concerns, is you know, they're never clear. They never say, yeah, this is fine. There's always something that could be wrong. And once patients see that there's always something that might be wrong, they focus on that. They focus, this is the cause of my back pain. It's this little nothing. And that is the same thing with meds. It becomes then the focus. So the focus is, what are you going to doing about this slight disc herniation that every human being will have at the age of 60? You know, what are you going to do about mine? Because I think that's the reason. So it just avoids the whole conversation, because it's not a helpful conversation. It's an expensive one in so many ways. So I think, you know, but I think you can do that with guidelines too, right? You don't necessarily have to say absolutely this person can't do it and this person does, because that can kind of create access issues. But guidelines about what to follow, when you can do this, when it's appropriate to do things, and trying to get at the whole idea of appropriate care use is really kind of the way to go, I think.
Yeah, I want to just expound a moment at what Bill had mentioned about the initiative Brian started here in Rochester, New York, with the imaging facilities, and that is to get the radiologists to change the language they're using on their MR reports so that it is not so catastrophizing.
Right.
Yeah.
It's really helpful and engaging. But if a patient gets that, which they now all can, because they all have access to their medical records, and when the primary care doc gets it, they can say, yeah, this is not a horrible thing. We don't need to worry about this.
Yeah.
Yeah. Well, just to move on to another section, from your perspective, sort of 60,000 foot view, if you could answer this, where do you see in the future world of spine, what do you see changing and what do you see not changing as we move forward?
Well, boy, that depends on so many things. But in my ideal world, what should change and what will be difficult to change, how about if I can reframe it like that? And what should change would be, again, more conservative care. It would be great if, and I just saw an article the other day where they're doing this with physicians as well, but placement of the early intervention people and use of early intervention pathways in the workplace where these things happen, where people are at high likelihood to experience back pain. So you get these early interventions, you get redirection, you get the appropriate kind of conservative care, you get reinforcement of patients about this. Yeah, let me describe what the course of events is going to be so they don't catastrophize. We can learn from a recent paper that compared actually opiates, 3 different types of opiates to, I think, Motrin in the ER, and found Motrin was actually a little more effective at acute pain control than the others. And so we tried to embed, make evidence-based guidelines that promote conservative care and use that whenever possible. So that would be the ideal. And I think, and the way to get there is to do actually studies that show that that's, from an employer's perspective, that's effective and efficient. And from a patient's perspective, it creates good outcomes for them. And from a societal perspective, assuming we want to maintain a workforce that is productive and decrease use of unnecessary social benefits, that would be a good thing. So I think the key thing, so then how do you get there kind of, and what are the barriers? The barriers are, me speaking as a physician, this happens all the time, is they say, well, here are the guidelines, say, this is cookbook medicine. I wasn't raised to do this, and back 20 years ago, people were fighting against electronic medical records, saying that they didn't go to med school to become typists. And now guess what? Everyone's doing it, and it changes. So I'm hopeful that things will change. There's a new generation that says it's not cookbook medicine. It's helping me with this wildly complex thing called medicine and human bodies, helping me figure out what works right most of the time, because it's really hard to keep up with. And so help me down this glide path. Let me know when I do need to do an MRI, but reassure me, frankly, that I'm not going to get sued if a patient wants an MRI and I say, yeah, it's just not indicated right now. So let's wait, let's put it up, because here's the studies, this is the evidence, it's not really indicated. So to use guidelines and implement them, to use teams, I think, that incorporate alternative medicine and integrative health kind of practices, because I think the other thing about use of chiropractors and physical therapists is they tend to have a much more holistic approach and more time to spend with patients than most primary care docs. So they're still booking in 30-minute intervals, and primary care docs are doing 10 and 15-minute intervals where they're trying to cover not only your back pain, but your heart failure and your dementia and 3 other things that you've got, right? So you focus on kind of teams that are around a spine kind of a practice, primary spine care practitioner, we've called it in different settings. I think Don Murphy, right, has done some work on that, and we think about kind of organizing healthcare around this particular high cost, high impact problem, to make sure that these guidelines are implemented, to make sure that the appropriate resources are there for conservative care, and make sure that we pursue kind of conservative care first. And then, frankly, I think, and we at Dartmouth have long articulated and advocated for this, that there are too many specialists, and the problem with specialists is there's supply sensitive care that's being provided. And the problem with supply sensitive care is if a patient says, I really want an MRI, and they're really insistent, and you say, oh, I'm following the guidelines, you don't really need it, this is all the evidence, they can walk across the street to the guy who doesn't follow the evidence and say, I want an MRI, and he'll go, sure. And lost a patient, and the society just lost all the benefit of all that work on evidence-based medicine. So I think so if you have fewer of the super specialists, the orthopods and the neurosurgeons and things like that who do these things, and patients can selectively be presented to them, and they I love surgeons, they're great people, they like to be in the OR, that's their forte, that's where they want to be. Let them be in the OR. Let them get the right patients who are going to be successful in getting that intervention to get to them, and not the patients who aren't. So there's a lot of screening, a lot of management of who uses this really, really expensive service. But I bet we could get away with half of the specialists that we have if we had more primary care docs, more integration of integrative health and mid-levels to kind of help kind of shape that and provide conservative care. We could save a fair amount of money, I think.
Great.
Well, thank you so much for your time, Dr. Weeks. It's been a good start to 2018 having this chat, and all the best for the remainder of the year, changing the nature and structure of healthcare. Yeah,
we should be done by June.
Yeah, easy.
Thank you so much, Bill.
My pleasure. Anytime.
Thank you so much.
All right.
Take care.